Hi everyone, thank you for joining me today. My name is Saira Kalia. I'm an associate professor of psychiatry and I'm the director for the Arizona Perinatal Psychiatry Access Line, and I will be talking to you today about maternal mental health, morbidity and mortality in the US as well as in Arizona, and kind of some unique ways that we can address the burden of the disease that we have. I have no financial disclosures, and let's start by taking a look at the rates of maternal health morbidity and mortality. I'm not going into mental health morbidity and mortality yet. I just want to make sure that we're thinking about how serious the scenario is in the US. This is 2020 data, and as you can see, the US far outstrips maternal mortality levels as compared to other industrialized nations. We're in the double digits, which as you can see, the rest of them are in single digits, and we're not going to talk about the fact that we're in the 20s. But I am a psychiatrist, so we're going to talk more about maternal mental health, and it is a huge issue. It is by far the most common complication of pregnancy. When you look at just associations with perinatal mood and anxiety disorders, you look at about 1 in 7 birthing persons having mental illness or substance use disorders, and you kind of increase that number to 1 in 5 when you become more inclusive. For comparison, people with preeclampsia, which pregnant people are frequently screened for, it's 1 in 25. Gestational hypertension is about 6 to 8%. Gestational diabetes is about 6%. So it's a pretty serious problem, and it doesn't definitely get the attention or screening and evaluation that it necessarily needs. And there's multiple reasons for that, which we'll talk about in a bit. And the other piece to keep in mind is that perinatal mood and anxiety disorders, maternal mental health, these are conditions that are treatable and sometimes preventable in terms of causes of morbidity and specifically causes of mortality. And as I said, mental health conditions are by far the most common complication of pregnancy and childbirth. Additionally, suicide and overdose are the leading cause of death for women in the first year following a pregnancy. The majority of mental health and substance use disorder related treatment occur in that postpartum period, which is something to keep in mind, which is why that first year following birth is such an important time to monitor moms and their babies. The one thing to keep in mind, and this is Arizona data, is when you look at the data from Arizona Department of Health Services 2016-2018 data that I'm quoting here, there is a significant amount of death associated with pregnancy or related to pregnancy. But the more horrifying statistic was the one that is at the bottom of your screen, which says 98% of pregnancy-associated deaths that are attributed to either mental health conditions or substance use disorders were ruled to be preventable, which is a pretty huge deal. Continuing in terms of discussing the Arizona Department of Health Services data in 2016 and 2018, the specific substances that were implicated in pregnancy-associated deaths were the following, with, of course, opiates being the number one substance that was implicated. I do want to call your attention to marijuana, and even though it says that marijuana was implicated 27.4%, this is the amount of substances implicated in death, which of course does not indicate the amount that this was just such a low substance use. Of course, we suspect that the use is much higher for marijuana in pregnancy. Additionally, when you think about the racial distributions and ethnic distributions, Black and Latina women are 33 times more likely to experience perinatal mental illness than white women, and this will continue to be the case in Arizona as well. So when you look at sort of the disparity within Arizona, I want to call your attention to, say, American Indian and Alaskan Native population. The American Indian and Alaskan Native population is responsible for 5.9% of live births. However, 11.1% of pregnancy-associated deaths due to mental health conditions or substance use disorders is found in American Indians. So it's a significant disparity in sort of the number of live births versus associated deaths. And these are huge issues, right? It's not just a matter of the mom is stressed out. This is clinical depression, clinical anxiety. These are I'm talking about clinical levels of disease, not just distress. And when you look at the data with regards to disease, they're very costly and have multi-generational consequences. And we'll talk about sort of the physical and psychological consequences in a bit as well. But there's, of course, a dollar amount to it and the cost of that. And I want to bring that up because depending on who you talk to and who's in the audience listening to this today. Maybe you need that information to keep that conversation going. Postpartum depression alone, it was an Earls article 2010 that talked about increased cost of medical care, inappropriate medical care, child abuse, neglect, discontinuation of breastfeeding, family dysfunction, and early issues with early brain development. But let's talk about the dollar cost, right? The cost of untreated depression, and this is just depression, I'm not talking about anxiety disorders, substance use disorders, sort of that whole spectrum of mental illness, is $32,000 per year, and sort of for that mother-baby dyad. If you were to apply that number to Arizona, we have about 78,000 live births in Arizona. 20% of that would be 15,600 mother-baby dyads. This would average about $375 million per year in terms of cost for Arizona. That's assuming that 20% got treatment, which is a generous assumption at that point, and the cost would be $477 million if nobody was treated. The other costs that are important and have to be considered are costs to the mother, the birthing person, the baby, and of course the community. And you have increased risk of miscarriage, serious medical consequences, antepartum, postpartum hemorrhage, gestational hypertension, suicide, preeclampsia, poor attachment, placental abnormalities, poor maternal nutrition, and just in general a huge struggle in terms of moms. Babies, they're at risk of preterm birth, NICU admissions, low birth weight, neonatal hypoglycemia, cognitive and motor delays, emotional problems, behavioral problems in the child. And of course, in terms of the community, there's the cost of loss of economic productivity, cost of preterm birth, and of course, cost of other maternal health expenditures. And this is important to keep in mind because healthy families lay the foundation for a productive society. But despite the prevalence of perinatal mental health and substance use disorders, 75%, 80% of people who screen positive for depression do not receive treatment. And this has devastating consequences. For depression alone, 60% of women nationally are never diagnosed and 50% don't receive treatment. And then when you sort of expand that bubble again outside of just depression, up to 80% of perinatal mood anxiety disorders do not receive treatment, which is huge. And part of the reason that birthing persons and moms do not receive the care and are not getting the adequate support that they need is because there is a huge shortage of mental health providers. And this is a healthcare professional shortage area map. And these designations are used in the US to kind of identify areas of severe shortage. Specifically, they are in 3 categories: primary medical, dental, and mental health. And this is the mental health map. As you can see, in Arizona, we have a severe shortage. The primary factor used to determine NHPSA designation is the relative number of health professionals related to the population. And so, of course, and they also keep in mind sort of higher needs, but this is kind of how they assess it. Let's take a deeper dive into what Arizona looks like. So when you're looking at sort of the behavioral health workforce by county in Arizona, this is a 2020 data set, and I want to make sure that I'm calling sort of attention to what we're looking at. So behavioral analysts, counselors, marriage and family therapists, psychiatrists, psychologists, social workers, and substance use counselors. So this is basically the professionals that we're looking at. Unfortunately, this data set does not include nurse practitioners. What I do want to point out to you is when you break it down in terms of providers, we have a high population, of course, in Maricopa, which is what we expect, followed by Pima County. But then when you kind of spread that out into looking at the surrounding counties, we have counties with as little as 1. And this is not just psychiatrists or mental health like MDs or PhDs. This is substance use counselors, social workers, behavioral analysts, pretty much everybody. So we have a huge disparity in access in Arizona's, in the state of Arizona. This is just a different way of kind of looking at the same information. Our behavioral health workforce is very, very urban focused with a 95.6% urban focus, which is a huge problem when it comes to the spread across the state and making sure that everybody gets care. When you take specifically psychiatrists in Arizona, in 2023, we have 915 psychiatrists in the state of Arizona, which is a huge, very low number for the amount of population that we have need for. And then there's a huge variation in capacity, people accepting insurances or, for example, access. And then, of course, very few of them are trained in reproductive psychiatry. This is the map, again, just based on psychiatrist, and then you'll notice that La Paz County, Gila County, Graham County, Greenlee, and Santa Cruz have no psychiatrists, with a huge amount focused in Maricopa. And again, as we expected, this is providers who provide medication-assisted treatment for substance use disorders are also heavily urban focused. So not only are we just in general a health services sort of professional shortage area as the state, specifically across the state, it becomes harder and harder. When you kind of take that and look at the map for OB providers, so any certified nurse midwives, OB physicians, the volume increases significantly as well. So we're looking in double, triple digits. Of course, again, you will find similar issues with regards to urban access versus rural access. And this is the reason why I'm bringing it up, is because mental health, maternal mental health is being recognized by multiple professional organizations and policymakers, and there is a consistent recommendation for screening and treatment. And it would be great if all of these patients could see psychiatric providers or mental health providers. However, that's just not going to happen because we don't have the capacity, we don't have the health care force at this point. And the reason why the perinatal period is sort of ideal for detecting mental health issues is because anyways, most mental health conditions are treated by primary care. But in that time period, a woman will see a healthcare provider an average of 25 times in that 2-year time frame, from conception to the baby's first birthday. So these are for her own health visits or pediatrician, etc. So there's a regular opportunity to screen and treat. So even in those rural areas, people will be going to go and seek treatment. And this is a great time to kind of catch them, if you will, and screen them. The problem becomes, even if they are seeing all these frontline providers don't often have the training, knowledge, or resources to address maternal mental health conditions, and nor are they typically reimbursed for doing so. And that becomes a very tough spot to put our frontline in terms of what to do. And so we need a solution in terms of making sure that these patients are taken care of, and the providers that are taking care of them in that front line also feel like they're supported and they have access to knowledge and resources as well. So one of the solutions for this very, very complex multi-layered problems is the idea of perinatal access line. So the goal being to build the frontline providers' capacity to provide mental health care, to increase access to care as well. So not just waiting for somebody to get in to see a reproductive psychiatrist, because that could take a while. How do we make sure that they get care earlier, faster, and at a standard evidence-based care? Perinatal access programs are designed to kind of address that gap. And the first access program launched in 2014 with MCPAP for moms out of Massachusetts. So we're about 9 years since the first program launched. We've got about 20 in the country, and they vary depending on what they offer across different states, because each state has kind of their own style in terms of practicing, etc. So they generally have 3 arms. So education, which is trainings, toolkits. They're going out and providing free education to providers and their practices and their teams. Consultation, which is the real-time psychiatric consultation. A provider picks up the phone and calls the access line, and on the other side is a reproductive psychiatrist they can talk to about the case and say, what is safe, what is not safe, how do I handle this? They sort of get that real-time support and guidance, which is evidence-based. And then some of them do the third arm, which is the resource and referral, which will help with community-based mental health resources. So for example, the Massachusetts program does have a resource and referral arm. The PAL program in Washington does not. The Periscope program in Wisconsin does not. And it varies also because depending on the state you're in, you don't have a lot of resources anyways to kind of attach to people. There was a lot of discussion in terms of do they work? And that's a big question to answer, right? Like we need a solution that actually works. And these papers are kind of looking at the implementation and how they worked out. So the first one is looking at how they're helping with depression care. This one was looking at utilization and quality, and they looked at volume of encounters and amount of patients served, as well as how often sort of they were utilized for training as well. And when they kind of took all of that down, they ended up realizing that MCPAP for moms cost $8.38 per perinatal woman per year, which is about 70 cents per month, which is a pretty low cost when you think about sort of the fact that they actually do work in terms of reducing the burden of disease. They also looked at the idea of, do we work in terms of long-term shifts? So they looked in building frontline provider capacity. So they found that and providers who had higher utilization rates for psychiatric consultations longitudinally had high predictive strong factors in terms of providing direct mental health care to patients with severe mental illness such as bipolar disorder. And they were able to demonstrate that utilization of MCPAP for moms was associated with improved sort of capacity and confidence amongst providers to provide the care, which is great. And there's still ongoing studies in terms of comparing different lines across different states and seeing what works and keeping that in mind. So with all of that said, there are, as I said, multiple perinatal psychiatry access programs that have been implemented across different states. And now, as of June 2023, we have one in Arizona, which is the Arizona Perinatal Psychiatry Access Line. And there's a few, we provide training. So you can call us and email us and reach out through our website and request trainings. They're about an hour and a half long, unless you request something different. And we are able to kind of do something specific to your practice. If you, depending on what your practice looks like, if you let us know, we'll try our best to kind of meet that need. And of course, it's free. The other piece is the phone line. So our phone line is, the number is 888-290-1336. And when you call us, the phone will be answered by our clinical navigator, who will collect some information about sort of the patient, the provider, and the practice. We need this so that we can take it back to the state and say, this is the counties we're getting calls from, these are the types of providers, and we can advocate for more services and resources. Additionally, as I said, this is free. There is no charge to you or your patient. There is, I think, some coding that providers can use to kind of code for higher complexity, and you're free to do that because you've sort of consulted as well. And the one thing that I will say is, right now we're half-time, and I'm recording this in September. By November, we hope to be full-time during business hours, which you can call, and hopefully we will be able to help you schedule consultations as well. So please feel free to give us a call. We'll be happy to help you take care of your patients. I do want to make the distinction that this is consultation, it's not telepsych, and so we're not doing direct patient care, we're doing direct consultation to providers. And the one thing is that we're a very lean setup, so in terms of cost effectiveness, what 1.2 FTE of such reproductive psychiatry could do in seeing direct patient care versus what we're able to cover in terms of the state is a pretty fantastic consideration in cost as well. The other thing is, even though we don't do direct resource and referral linkages, we have been collating resources across Arizona. So on our website, you will be able to find resources that are spread out across counties. So you can click on your county and you'll get resources within your county. And if you are going on our website and you're finding, hey, I do this and you don't have me up there, please feel free to email us at team@apal.arizona.edu, and we will be happy to include some included services. I'm not advertising for people, just keeping that in mind. So that's kind of what I wanted to leave you guys with. We're a free statewide access line, and I really hope that you will consider giving us a call, and please provide us any feedback that you do have, and hopefully we will hear from you. This is our website and the team email address. I'm going to hold on here for a quick second just so you can take a screenshot, take a pause here. I hope this was helpful. Thank you so much.